Labor News Conference. Welcome to another edition of Labor News Conference, a public affairs program brought to you by the AFL-CIO. Labor News Conference brings together leading AFL-CIO representatives and ranking members of the press. Today's guest is Bert Seidman, director of the AFL-CIO's Department of Social Security. Quality health care as a matter of right for all Americans is a long-standing top priority goal of the AFL-CIO. In recent years, a number of proposals for such a system have been laid before Congress. We have seriously examined all of them and measured each against what we are convinced are basic standards that are essential to a solid foundation for any such program. Here to question Mr. Seidman about what the labor movement considers essential elements of any system of national health insurance, how various proposals now before Congress measure up to those requirements, and prospects for creation of a system of national health security, are Judith Randall, medical and science writer for the Washington Star-News, and Donald Finley, labor correspondent for United Press International. Frank Harden speaking. And now, Ms. Randall, I believe you have the first question.
Mr. Seidman, national health insurance has been a topic of discussion for many years now in Congress. Has anything happened recently which has changed the outlook for various proposals or made passage more imminent?
Ms. Randall, I don't know if anything has happened which will affect the date when national health insurance will be enacted, but there has been a recent development which is of some importance in this area, and that is that Congressman Mills, the chairman of the House Ways and Means Committee, and Senator Kennedy, who is the chairman of the Health Subcommittee in the Senate, have introduced what might be called a compromise bill. It's a compromise bill because Senator Kennedy had been one of the chief sponsors of the health security bill, the bill, incidentally, which the AFL-CIO has been supporting and continues to support. And the health security bill would go further toward making health care a right than the Mills-Kennedy bill.
Well, Mr. Seidman, what do you think of the prospects for getting some legislation passed this year on health insurance?
Mr. Finley, that's a very difficult question to answer because I don't know, for example, just how long the House of Representatives first, and then depending on what they do, the Senate may be dealing with the question of Watergate and impeachment. Since we can't predict this, we don't know how fast they're likely to act on other legislation. I tend to think that in the light of the very heavy agenda that the Congress has at this time, plus the time that will have to be devoted to the impeachment question, and the fact that there will be congressional elections in the fall, that the chances of enactment of national health insurance legislation in this Congress are rather slim.
Well, do you feel that some sort of health insurance is an idea that its time has come and that eventually there will be some legislation passed along this line?
Mr. Finley, my answer to that is that it is an idea whose time has come. But when you say some form of health insurance legislation, I get a little bit nervous. The AFL-CIO wants to see the kind of comprehensive national health insurance legislation which will cover every American for quality health care. And if that kind of legislation is enacted, we will, of course, support it. That's what we want to support for enactment. We're not interested in seeing just any kind of legislation whose sponsors may call it national health insurance.
Would you prefer no legislation then to some of these bills that are there?
I would say at this time we would prefer no legislation to legislation which would clearly be inadequate in terms of making quality health care available to the American people.
Mr. Seidman, you speak of the Kennedy-Mills proposal as being a compromise when compared to the original legislation sponsored by Mr. Kennedy. Could you be specific about in what ways the general public might suffer from said compromise?
Yes, I think I can indicate some of the major differences between the Mills-Kennedy bill and the Health Security bill. Incidentally, the principal sponsors of the Health Security bill are Congresswoman Griffiths and Congressman Corman, who are both members of the Ways and Means Committee in the House of Representatives. The major difference is that indeed the Health Security bill would make health care a right for all the American people, and the Mills-Kennedy bill simply would not. Now, why would it not? In the first place, the Mills-Kennedy bill has a stiff means test for poor people to establish their right to reduced, what are called co-payments, deductibles and co-insurance, which are payments that they have to make in order to be able to get any benefits at all under the program. Since poor people might not be able to afford those co-payments, this clearly does not make health care a right, and besides that, they would have to provide all kinds of information in what we consider to be very demeaning means tests. Secondly, for other people, there would be very high deductibles and co-insurance which would stand as financial barriers against their possibility of obtaining the health care that they need. There are some gaps in terms of the people who are covered by the Mills-Kennedy bill, whereas the Health Security bill makes health care, as I said, a right for every American. Every American would be entitled to the benefits and the very comprehensive benefits that there would be under that legislation. Now, the gaps in the Mills-Kennedy bill are not all that great. There are some important groups, however. They include, for example, new workers and their dependents if the worker is employed less than 25 hours a week. Most divorced women who never worked. We don't know exactly why there are these particular gaps, but it stems from the failure to begin with the principle that health care is the right of every American. Instead, the Kennedy-Mills bill goes at it from the point of view of trying to establish coverage for particular groups, and some people get lost in the shuffle. Well, there are other important differences too, but those are some of the differences.
We're going along talking as if the Kennedy-Mills bill and the original Kennedy-sponsored proposal were the only possibilities. It seems to me that
No, there are others.
We should perhaps look at the administration's bill and see how it differs from both of these others.
Yes, there are differences between the administration bill and the Mills-Kennedy bill and the Health Security bill, and I should say also that there are other candidates as well in this picture. There's a bill sponsored by the American Medical Association, and another bill sponsored by the hospital groups, and a third one sponsored by the insurance companies. So there's no lack of bills that are called national health insurance. But the Nixon administration bill, I think, has to be considered perhaps the third of the three major bills, and in many respects that bill is even worse from our point of view than the Mills-Kennedy bill. For example, the Mills-Kennedy bill does provide for compulsory coverage. That is, all employees, other than the new workers that I mentioned before, who are part-time workers, but by and large, all workers and their families would be covered. The Nixon plan doesn't do that. The Nixon plan covers employers, but the employees have the right to determine whether or not they want to be covered. And in order to be covered, they have to pay 1/3 of the premium cost plus deductibles and co-insurance, which are even more onerous than those in the Mills-Kennedy bill. Another difference is that in the Health Security bill, there is no role for the private insurance companies at all, except as representatives of the providers of care. In the Mills-Kennedy bill, it would be administered by the Social Security Administration, but the Social Security Administration, in turn, in the pattern that has developed under the Medicare program, would use the insurance companies as so-called intermediaries. We think that this is not necessary at all, but that's what that bill would do. The Nixon plan relies entirely on the private insurance companies, and they have been notoriously uninterested in controlling costs or promoting efficiency or quality in the healthcare system.
To go back for a moment, what's the danger in having a voluntary plan so that people didn't have to sign up?
It means that people who couldn't afford to pay or would not be eligible for the benefits under the program at all. It would mean that people would still be denied the health care that they need. And the important thing, it seems to me, is to make health care a right for everybody, and that's what the health security bill would do.
Mr. Seidman, it would appear to me that a program like this of providing health care to everybody is going to cost an awful lot of money. How would these the various proposals finance this system of health care?
Well, before I get to the financing as such, Mr. Finley, I'd just like to correct a misimpression that a lot of people may have about the cost of a national health insurance system. We are now paying approximately $90 billion a year to provide health care for the people of this country. Next year, it's likely to be $100 billion or more. On the day that any national health insurance system gets underway, it is going to cost that amount of money. The question then becomes not the amount of money, because the amount of money would be approximately the same under all of these programs, except that some move more vigorously in terms of controlling costs, and that's true of the health security bill. But the amount of money at the beginning would be approximately the same. The question is, how is it going to be financed? Is it going to be prepaid, or are people going to have to make the payments at the time that they're sick and at the time that their incomes tend to be down? Are poor people going to pay more or less? Are people going to have to pay for heavy premiums, or are they going to be covered by Social Security taxes, which are a system which is fairer to the people that are involved? So that the question then becomes what type of financing rather than the cost of the program itself.
The Social Security taxes are already awfully high, and people are starting to be very aware of it. How would you propose to overcome that objection?
I think that in the first place, we're not proposing to raise Social Security taxes under the health security bill as far as employees are concerned. Employees are already paying in their overall Social Security tax 1% for Medicare. Under the health security program, that 1% would continue, but it would cover care for the worker and his family, and not just for the worker when he becomes old and retires or becomes disabled, or which is the way people are covered by Medicare now. Health security would be financed also by a 3.5% tax on payrolls paid by employers, and half of the total amount of money would come out of the general revenue of the federal government. We think this is a fair way of financing a national health insurance system. The Nixon plan depends on...
What about the self-employed, though, who
the
don't...
self-employed would pay 2.5% of their incomes under the health security bill. The Nixon plan depends on financing, first of all, from premiums. The premiums would be compulsory as far as employers are concerned, and therefore they would be in the nature of a tax. But instead of the tax going to the government, as most taxes do, these taxes would be paid directly to the insurance companies, and one could expect that the business of the insurance companies as well as the profits of the insurance companies would more than double if the Nixon plan were to take effect. In addition, and the employee would be required to pay 1/3 of that premium cost. In addition to that, as I've already said, there would be these heavy deductibles and co-insurance, so that a family would have to spend $1,500 before it would be eligible for benefits under the program without any financial barriers in the form of coinsurance and deductibles. And then, because the plan doesn't cover all services, there would be additional out-of-pocket payments. We've estimated that only a very small proportion of people covered by either the Mills-Kennedy bill or the Nixon plan would be eligible for full benefits during a year.
In the past, Mr. Seidman, the health industry has been one of the nation's most inflationary, if not the most inflationary. Do you see a return to this trend and a resurgence of inflationary trends before we have national health insurance?
It would appear that that is the case. For example, physicians' costs have been going up quite rapidly within the past few months. They had the increase had moderated somewhat in the year or two before then. We are beginning to see the same thing with hospital costs, which are also going up rapidly. And from my point of view, that's all the more reason why we need a national health insurance with effective cost controls and built within the program the kind of measures which will make the entire healthcare delivery system more efficient so that we can begin to control the costs of medical care. And for those doctors, for example, who are paid on a fee basis, we need fee schedules so that we get some kind of a handle on these costs. These are, incidentally, some of the features of the Health Security Bill, which would help to control the cost of care after the national health insurance system is established.
In other words, you're saying that doctors' fees and other fees would be set at a certain rate, and they would not be able to exceed that?
Under the Health Security Bill, these would be negotiated with the physicians, but then once the schedule was adopted, they would not be able to exceed it if they wished to be paid under the program. There would be nothing to prevent a doctor, if he could find a patient who was willing to pay out of his own pocket, to provide care at whatever fee he wanted to charge, but he couldn't get any money under the program itself. Now, that's not true under either the Nixon plan or the Mills-Kennedy plan. In each of them, those plans, the doctors, even though they did not subscribe to the fee schedule set up under the plan, and incidentally each contemplates a fee schedule as one feature of it for certain recipients at any rate, but the doctor could get reimbursed by the plan even though he didn't subscribe to the fee schedule.
But he'd be only reimbursed to the level of the fee schedule. The
Yes,
patient would
he
be
would.
responsible for the rest.
Yes, the patient would be responsible for the rest, whereas under the Health Security Bill, once the fee schedule is adopted, if the doctor wanted to get any reimbursement under the plan, he would have to keep to the fee schedule, and he could not impose additional onerous charges on the patients as the doctors could do under the other two plans.
Well, would the fee schedule also apply to hospitals and drugs?
No, there wouldn't be a fee schedule for hospitals, but there would be what are called prospective budgets. In other words, these amounts would also be negotiated, and they would be held during the year to the amount of money which had been determined in advance.
In an era of impeachment politics, do you think this kind of detail is going to get attention from the public and from politicians, and it's going to be widely discussed?
Well, I've already said I don't think that this kind of legislation will be enacted this year, but I think it will get plenty of attention in the next Congress.
Thank you. Today's Labor News Conference guest was Bert Seidman, director of the AFL-CIO's Department of Social Security. Representing the press were Donald Findlay of United Press International and Judith Randall of the Washington Star-News. Frank Harden speaking, inviting you to listen again next week. Labor News Conference is a public affairs production of the AFL-CIO, produced in cooperation with the Mutual Broadcasting System.